Our next to talk is going to be Dr. Matthew Armfield in conjunction with Katie Menard, physical therapist. Dr. Armfield is assistant professor in the Department of Pediatrics here and the medical director of the Pain and Advanced Complex Disease. He went to Milwaukee for medical school, did his residency here, and did a fellowship in pain management at Minneapolis Children's Hospital. And he's been on our pancreatitis team for the last couple of years. Great addition to the team. And physical therapy also. Katie Menard is from my alma mater, St. Catherine's in St. Paul. She's been a physical therapist here for 13 years working with our children with chronic pancreatitis. So we have a great team. Thank you.
Thank you, Marie. Thank you, Sarah Jane, for allowing me to come and talk. Today, I'm going to talk about using an integrated pain management program for children with pancreatitis, both acute and chronic. To do so, I want to talk about a patient that her story is unfortunately all too familiar to those of you who are familiar with the diagnosis of chronic pancreatitis. So this is Allison. She's a beautiful 11-year-old girl who, since the age of 3, has been experiencing horrific amounts of abdominal pain with nausea and vomiting. She was diagnosed with hereditary pancreatitis 1 year after her symptoms started. So as you heard from Sarah Jane, that was actually a quicker diagnosis than that can happen. So at first, after her diagnosis, she would have pain episodes just a few times a year. But then they became a lot more frequent. And starting 2 years prior to me seeing her, she started to have pain every day, nausea every day, with intermittent bouts of very distressing vomiting and fatigue. She's been hospitalized countless times with suboptimal pain control while she has been hospitalized due to fears of giving opioids in children because they thought that they would become addicted to them. As an outpatient, things weren't much better. She didn't have a pediatrician who was comfortable prescribing strong pain medications to her because of her age, nor did they feel comfortable treating the complex condition of chronic pancreatitis. So she was kind of lost. In fact, she got a prescription for medical marijuana because no doctors in her area would prescribe strong pain medications just so she could survive the day with less pain, not no pain. Now, when she has a pancreatitis attack, her parents don't take her to the emergency room anymore because they never do anything to help my daughter. Her pain was severely affecting her life in countless ways. Although she was living a relatively normal life between attacks just a few years before I saw her, she now confined herself to a wheelchair because she found it too difficult and too painful to walk around. She was having difficulty falling asleep and difficulty staying asleep. Because of the fatigue and because of the pain, she stopped going to school. And because of that, she became socially isolated and her social life became virtually non-existent because she didn't have any interaction with her peers at school. And frankly, they didn't want to hang out with her because she couldn't do anything because she was safe that she was in too much pain. So her life was really turned upside down by her diagnosis. She's depressed all the time, too anxious to do really anything due to the fears of having a pancreatitis attack when she's out with her friends, and chronically fatigued due to the condition and due to lack of sleep. Eventually, when I met her, I asked her what a good day would be for her. And she replied, quote, "When my pain is less than 5 out of 10 is a good day for her." And then she said she's had about 2 good days in the last month. I then asked her when the last time she felt pain-free. Her response, I don't know. So, unfortunately, Allison's story is not unique. I've seen many patients who have stories very, very similar to hers, stories of daily pain, stories of doctors who don't know how to treat their pain, and parents struggling to struggling to figure out how best to help them. Stories about their world turned upside down because of pain, who cannot participate in life due to pain or even because of the fear of pain. And for those of them who do actually manage to push through the pain and try to live a normal life, they have stories of friends, loved ones, and even doctors telling them things like, you don't look like you're in pain. Pain's all in your head. You just want attention. You need to learn to live with it. And horribly, a lot of times they hear your pain is not real. Well, I'm here to tell you that today all of those statements are a bunch of crap. Your pain, my patient's pain, is very real. You are not crazy, you are not making it up. Yes, technically the pain is all in your head because that's where your brain is, and if you didn't have a brain, you wouldn't have any pain. But this idea of all your pain is real can be very difficult for people to understand, especially for someone who has not lived the life of someone with chronic daily pain. That's because pain is actually a lot more complicated than most people understand, and this complexity is what makes pain so debilitating and many times very, very difficult to treat. So I want to talk a little bit about that, just so you can get an understanding of pain and hopefully a way to explain this to others who might be questioning, unfortunately, the pain that you or your child might be having. So, this is Ted. From the outside, Ted looks like a typical 16-year-old male. However, on the inside, Ted is not a typical 16-year-old male. Ted has hereditary pancreatitis. So, several times a year, his pancreas, as Dr. Schwarzenberg explained, becomes inflamed. This causes his nerves to send signals up to his brain saying, hey, you're in pain. There's a problem here. You need to get this fixed. So he goes to the hospital, gets treated in fluids and pain medications, and 4 to 5 days later for him, his pancreas calms down and his pain goes away. And therefore, he can go about his typical 16-year-old life. So this type of pain that he just experienced is the most familiar type of pain that you probably know. And this is pain from tissue damage. Your pancreas is inflamed, something is wrong, something bad is happening, your nervous system tells your brain that it's a warning sign, you need to get this fixed. So we call this tissue damage pain. Thankfully, medications for this type of pain can do a pretty good job in lessening the pain. So medications such as Tylenol, ibuprofen, opioids can actually do a very, very good job of this, things like morphine and oxycodone. So we can treat the pain until we can fix the problem, however we decide to do that. So one day, Ted, he has pancreatitis again. His pancreas becomes inflamed, causing his nerves to send signals to his brain again, saying, I'm in pain again. And again, he goes to the hospital, and he again is treated with IV fluids, pain medications, and 4 to 5 days later, his pancreas calms down. However, he still has pain. His nervous system, even though there is no new tissue damage that's going on, his nervous system has become so sensitive and so hyperactive that it is still sending pain signals to his brain saying that he is in pain. So therefore, in this case, the pancreas is not the major problem. His overactive nerves are the problem. And so this type of pain is a different type of pain, and we call it neuropathic pain. Neuro meaning nerves, pathic means source of the pain is from the nerves. So this can be a little bit more difficult to treat. Certain medications can do a good job, but they're different than those that can treat acute, the tissue damage pain. And other modalities, which I'll talk about later, can help with that as well. But remember that Ted still has hereditary pancreatitis, so there's a very good chance that his pancreas would become inflamed again, and causing tissue damage pain on top of the pain he's already experiencing from his hypersensitive nerves. So now he has two different types of pain going on. Now, if either neuropathic pain or tissue damage pain goes on for 3 months or longer, then we classify that as chronic pain. So this is the pain that you're experiencing every single day outside of pancreatitis attacks. So he has neuropathic pain, tissue damage pain has gone on for a quite long period of time, so he has chronic pain. And obviously, this leads to depression, anxiety, fear of more pain, a debilitating lifestyle, and which can then manifest as psychosocial, spiritual, and emotional pain, which is very, very real. So as you can see, pain from chronic pancreatitis is extremely complex, and the majority of medical providers do not know how to treat this type of total pain. So that's why, unfortunately, you hear statements like, you're just going to have to live with the pain. Well, no, you do not need to learn how to live with the pain. You can become pain-free. However, in order to do so, you do need to learn how to control pain and not let pain control you. And this requires hard work, requires dedication from you and your parents, and support from loved ones and support from medical professionals and time. So you can consider this whole journey as really like a mountain, really of hard work. So at the beginning, there's a lot of work to do to get our patients ready for the TPATE operation. And then really afterwards, it's still hard work, but it is a lot easier because they've done it already. And actually the post-op period we found for our patients is actually much easier than the pre-op portion. So at the University of Minnesota, hard work starts right away. It's at the TPATE evaluation. You and your family will meet with a whole host of physicians, and including our team, which in the initial evaluation includes myself, my colleague Molly Hagan, our nurse practitioner on our team, and with a physical therapist, either Katie, and we have our other physical therapist out there, Kayla, who've done a wonderful job in helping out. So we evaluate the state of your pain, how bad the pain is. We evaluate how it impacts your function, taking a look at school, taking a look at activity, taking a look at sleep, and taking a look at social life. We evaluate the medications that you are currently on and that you have been on in the past to make sure that we can develop a proper post-op and pre-op pain medication regimen for you. But also, very importantly, we also take a look at the non-medicine things that you have done to get rid of pain. Because like I tell my patients, what's better than medications to treat pain? Non-medications to treat pain. And so all of this information is then used to really develop what we call a prehab program for those who are qualified for a total pancreatectomy with auto islet transplant. So this prehab program really consists of majorly of 4 parts, with a 5th part being a supportive part of the other 4. And that is a combination of physical therapy, integrative medicine, psychology, and last, getting your life back to normal, with medications then helping you achieve all of those. And these things all have to be done at the same time. You can't solve a multidimensional puzzle like chronic pancreatitis and chronic pain one simple piece at a time. You have to do it all in an integrated approach, and that's where our program comes in. So I'm going to turn it over to Katie to talk about how physical therapy fits into our integrated program.
Hello. A lot of people ask why physical therapy is so important prior to surgery. Usually people think of physical therapy coming into play after a surgery or after an injury. But we recommend that our patients establish care with a physical therapist prior to coming for surgery. What we found is that when people have chronic pain that impacts their daily life, it also affects their activity level. So when you're in pain, you're probably not as active as you normally are and aren't able to do things like go to school, go to the grocery store, participate in sports teams. So our patients become deconditioned. They'll lose strength, flexibility, stamina, and the more pain you have prior to coming for surgery, the longer and the more work you're going to have to do to recover after that surgery. Also, establishing care with a physical therapist prior to surgery makes reestablishing care following surgery upon returning home that much faster and easier, because we want our patients to be able to transition back to their previous activities that they enjoy, sports, going to school, but they also need to do that in a safe manner post-surgery. And a physical therapist can help them transition back by establishing a personalized and safe program to get them back to their activities. But usually when I mention this, it inflicts fear and anxiety. So people always ask, like, but how can I do physical therapy when I have pain every time I move? And that is the million-dollar question. But a physical therapist's job is to help a person gradually improve their physical mobility. Movement is medicine. Too much, you get sore. Not enough, you get zero improvement. It's a physical therapist's job to help that person find the right dosage so that they can be successful. Sometimes a little trial and error, just like with any medication, but physical therapy, movement is medicine. The first session with any patient is going to be just starting with setting goals. And then once you have those goals established, then it's learning how to pace yourself and how to gradually expose yourself to activity so that you can get back to what you want to and achieve your goal. And a physical therapist can help progress that person then to completing an aerobic, also exercise program, which also inflicts fear because people are like, I can't even walk. How can I do aerobic exercise? But we want aerobic exercise because studies show that aerobic exercise decreases stress, improves energy, improves sleep, memory, mood, concentration, appetite, and of course improves pain. All of those aspects of someone's life are impacted by chronic pain, and aerobic exercise improves those.
So the second recommendation is that of integrative medicine. And I get a lot of like, what is integrative medicine? Well, those are all the non-medicine things that I ask about to help reduce pain. And those can include things like deep breathing, meditation or mindfulness, self-hypnosis, my favorite, guided imagery, biofeedback, progressive muscle relaxation, and a whole host of other techniques. Now, again, a common question I hear about this one, are you saying that my pain will just go away if I just do some deep breathing? This is a common thing I actually hear too. And also then I will actually explain that they think you're an idiot and this doesn't work, because I've tried it. Or this is just crystal waving, like hippie mumbo jumbo, like what are you talking about? It can certainly sound like that, but actually there is some science behind those modalities helping reduce the pain sensation. So in order to explain that, we'll bring you back to Ted. And remember that he does have chronic hereditary pancreatitis. So again, pancreas is sending signals up to his brain saying that he's in pain. Because it's hereditary and because he has chronic pain, his pancreas may or may not be inflamed. But instead, this time, Ted has learned a wonderful, amazing integrative medicine technique called self-hypnosis. So when he has pain, what he does is close his eyes and really imagines himself at his favorite place. So this powerful imagery of really immersing your mind into where you want to be, wherever that is, it could be the beach, it could be the forest, it could be in space shooting space aliens, whatever you want to do. It triggers the memory centers of your brain to remember that great experience and all the emotions that were behind that great experience. And that, therefore, activates another nerve that goes down from your brain to your spinal cord and actually stops pain signals from going up to your brain. So I call this the stop the pain nerve. And with daily practice of an integrative medicine technique that you like, that you find to be useful, you can learn to retrain your brain to activate this nerve at all times. So that will lessen, not get rid of, but lessen the pain that might reach your brain. Obviously, when pain gets to a certain level, no amount of deep breathing will help, and that's why we have other things that we can try. But also, this can help and prevent pain from actually getting to that point in the first place. The third recommendation is psychology, in addition to the integrative medicine and the physical therapy that we've already talked about. So working with a psychologist, therapist, or counselor is extremely important in helping you overcome the pain and the emotional baggage that comes from pancreatitis and chronic pancreatitis. So again, I'm not crazy or depressed. Why do I need to speak to a psychologist? And a lot of times, too, when talking with patients with any sort of chronic pain problem, regardless of the cause, a lot of times they'll hear statements like, oh, you need to go see a psychologist and nothing else. And so then they're left with the feeling from their doctor that you don't believe me, you think I'm crazy, you think it's just all in my head. Why do I need to speak with a psychologist? But anyone with chronic pain will have more stress, more anxiety, and more depression than someone who doesn't. And therefore, the more stress, the more depression, the more anxiety will make their pain worse. And when their pain is worse, then they will have more stress, depression, and anxiety, which makes their pain even worse. And it's just this vicious cycle where they get more pain and get more depressed and get more socially isolated. So working with a psychologist is actually standard treatment for all of our patients that come through our program. It is not optional, and it helps with both the work beforehand in reducing the stress and anxiety around pain, which will then indirectly lower their pain, but also it helps after surgery. A lot of these patients have been living the life of a with a person with a chronic disease for countless number of years. And actually, it can become quite difficult after the surgery to become disease and pain-free. It actually requires a lot of adjustment for both the patient, and I see that a lot with families too, because they've been so invested for years and years and years in being their son or daughter's caregiver that when that part is actually taken away because the problem is fixed, they need to replace that with something and they don't know how to handle these emotions. So that's why psychology can be very, very important before, actually while in the hospital, and then afterwards for both the patient and their families. So just like physical therapy, what Katie talked about, establishing a relationship with a psychologist before coming for surgery is, again, something that we strongly encourage, and so they can continue that relationship once they go back home. And so the last of the four required recommendations requires normalizing your life. And this, I think, is the most important thing I want to have you take out of this presentation, is that to get pain under control, you have to get your life back to normal first, and then your pain will get better. And it does not work the other way around. So what is the aspects of a normal life that we're looking at? Well, it's what I talk about in our initial evaluation. It's the 4 S's: sleep, sports, social, and school. So for first, you need to have good sleep hygiene. So you need to go to bed at a consistent time. You need to get up at a consistent time, avoiding weekend sleep binging, keeping the bed as a sleep-only zone. Stop using all screens 30 minutes before going to bed. Can you imagine what happens when I tell that to a 16-year-old? I get really bad looks. But it's very, very important. That bright screen in front of your eyes only signals to your brain that it's still bright outside, and so it's very, very difficult to actually move into that state where it will allow you to sleep. What you do during the day is also important to your sleep. No naps. That throws off your circadian rhythm or your day-night cycle, and so when it comes to your normal bedtime, you're not tired. So you stay up, and that can promote reversal of your day and nights, which is very difficult to treat. So that's sleep. Sports. You need to participate in sports or some activity. Really, for our program, we already have them involved with the physical therapy portion, so that kind of takes the place of that. Social. You need to lead a normal social life. So you should not let pain get in the way of doing things with your friends or having fun. I require my patients to do something fun every day. I tell them I'm really not that bad because I'm describing you fun. So you need to find something that you enjoy doing and keep doing that. And finally, what can be the most difficult recommendation that I've made out of everything I've talked about today is the last, and that's school. My recommendation is to go to school. School is extremely important, actually a really good marker of how pain has impacted one's life, because it involves having good sleep the night before so they can properly function at school. It requires activity from going to class. It requires being social during the day with your teachers and with your friends. And so therefore, it's important to go to school. This can be extremely difficult for parents as well, because I don't have kids of my own, but I can only imagine how difficult it can be to send them off to school when they are crying that they're in so much pain. It's probably awful. So, it's important though. Now, just like we wouldn't ask someone who came for evaluation to run a marathon the next day, it's unreasonable to ask that if they have been out of school, to immediately go back to school full time. So again, like physical therapy, it is a slow approach, and hopefully our goal is by the time surgery comes around, they're back in school full time. And lastly, medications. Now, medications are really the only optional part of our program. However, the vast majority of our patients who come in are on some medication or another. But medications in and of themselves will not cure your problem. And so that's why the other four are most important. Medications, however, can do a wonderful job in supporting you in getting the first four recommendations done. So proper medications can be very, very helpful. Incorrect medications for a chronic pain, which include medications like morphine, oxycodone, Dilaudid, can actually make chronic pain worse. So that's why we go through an extensive medication history. We stop medications that won't work, and we start patients on medications that we know do a good job. And again, it's a slow transition off some of them and onto others. Again, our hope is that you would be off of or down to as little opioids as possible before the surgery, so then after the surgery, they're as effective as they can be. So that is our program. So with hard work before the TPATE, with the 5 parts of our prehab program, you can get to the surgery successfully, and for the recovery afterwards. The recovery afterwards really involves the same 5 things: physical therapy, integrative medicine, psychology, normalizing your life with the help of medications. And so I say again, the hard work has already been done in the beginning. Afterwards, you've done it already. And so you're very, very familiar with the program. And so you just continue that after you get out of the hospital, and you continue that when you go home, so you can become pain-free. Now remember, our patients are superheroes, okay? But just like Superman can't save the world alone, he has a team behind him, as do we. So you will meet medical professionals, anesthesiologists, physical therapists, psychologists, integrative medicine specialists. We work with our child and family life professionals. We work with our music therapists and our social workers, all to support you getting up to the surgery and afterwards, because it takes a team to save the world. It also takes a team to get rid of and cure pain. So, going back again to our patient, Allison. She went through the evaluation. We presented the program to her and her parents, and understandably, they were not happy with what we had to say, because they did not realize of the amount of work it takes beforehand to get ready for the surgery. They had the same questions that we talked about. Remember, Allison was in a wheelchair and found it very, very difficult to move around because of pain. But she, with hard work, started doing physical therapy. She started walking every day, slowly adding on distance each day. She found a psychologist who also, so she just started seeing, who also taught her some wonderful directed breathing exercises that she practiced every day. She went back to school, very slowly at first, starting with 1 class a day, and then slowly, every couple of weeks, adding on 1 more to make that transition much easier for her. In fact, 2 months before her TPATE, she was going back to school full-time. She made remarkable progress. Just before her TPATE, she went on a trip with her family to New York City, and they ended up doing a sightseeing tour when she walked on her own for approximately 8 hours. Remember, she was in a wheelchair before when I first saw her. So now she underwent a TPAPE. Her postoperative course was painful, but certainly not as hard as the months leading up to the surgery. She's now a happy teenager who is pain-free, living life to her fullest as she wants to. So that is our program. Thank you very much. If anyone has any questions, we'd be more than happy to answer them. We would use almost the exact same model. The medications might be slightly different, and the goals might be slightly different, especially with the timeline. But the program here really is focused more on chronic pain than chronic pain with pancreatitis. The unique with this population is that you can have acute pancreatitis on top of that, which makes medication management all that more difficult. But it would be the same thing for anyone who's not a candidate for surgery, shelf support to get their pain down as much as they can. Yeah, Marty. That's a great question. Unfortunately, there are quite literally only a handful of pediatric pain specialists in the country, and there's probably about only 20 pediatric chronic pain clinics in the country, not including ours here, because I see such a specific population. So, and pain training and medical school and in residency for medical professionals is extremely lacking, and if you talk about even pediatric pain management, that's virtually non-existent in training. So it is actually a very big problem. And so a lot of physicians, unfortunately, do not know how to manage pain, and they do not know how to incorporate this comprehensive approach to treating pain. So one thing I offer anyone who comes through our program, really no matter what, I am always available for help and for consultation. Once they go back to their home city, if they have questions, if their primary care physician has a question, pediatrician has a question, or if they are seeing a pain specialist have a question about this specific problem, they can always contact our team at any time and we can provide assistance. Mm-hmm. And unfortunately, and I haven't treated adult pain patients, but I would agree with you. And I think a lot of the recommendations that I have here, even though it's specific to a pediatric population, I think that can be easily translated up to the adult population. Something actually was quite novel, usually goes the other way around. And unfortunately, yes, you can see practically a pain clinic on almost every street corner now. But if you go and actually look at what those pain clinics are doing, most of them do not spend the proper amount of time with their patients to fully understand their pain. And most of the time, they just prescribe medications, which you can... Or do interventional procedures, which again usually do not fix the problem, they only put a Band-Aid on the problem. Or medications was just that fifth optional step that supports all the other four. Problem is, all the other four takes hard work and time. For our initial evaluation, I spend 2 hours with our patients initially, and certainly I appreciate the university for understanding how much time it takes to treat these patients fully. But not every physician has that luxury, and so hence you get substandard care. Anything else?
I am not personally trained in that, but I have on occasion recommended that so that when they go home to find a therapist that specializes in that, particularly people that have had multiple surgical interventions on their abdomen. So yes, I have made that recommendation before, but I'm not personally trained in it.
Thank you.
You have been disconnected from the meeting.